Welcome to the June Respiratory Therapy Department meeting. Thank you for joining. We're going to start this meeting off with a reflection. This is a quote from Amelia Earhart. The greatest work that kindness does to others is that it makes them kind themselves. I've got someone in the chat. Have no mic and hi. Okay. Hi, Josh. Thanks for joining. Okay, so the agenda in brief this month, we have just some conclusion of our recent survey with TJC. We're going to go over accounting, some current events, some new things that are happening in the hospital. Again, a hanging slide team, just ongoing expectations. Employee satisfaction. I know this is a fan favorite in the department. We have the results of the My Voice survey. We're not going to go over any specific item this month, but rather I have compiled the results and just will put them out for kind of a brief overview. And then as we do throughout the rest of the fiscal year, we'll be kind of teasing out some of the kind of hot spots that to solicit some information from you all collectively, ways in which I can make the department even better for you. Then we're going to go over again some hanging slides of education, the Unit-Based Practice Council, scanning scores, positions, the Kudo board, and then open forum and questions. So the Joint Commission, they have come and gone. This was June 17th through the 19th. We had anticipated that they would be coming in July. They came early, but honestly, all of the people in administration, myself included, having gone through several mock surveys and TJC surveys, this survey that we just went through here at Woodland was you couldn't have asked for a better one. We had great surveyors. We had a lot of work being done in the background from a lot of different leaders, a lot of different employees, from our environment of care to our facilities to our equipment. In no small part, respiratory therapy played a huge role in our success, in ensuring that all of our machinery, all of our equipment, if it was out of date, if it wasn't dressed, if it wasn't covered, that it got to be so over the course of these last few weeks. With that said, we had only one conditional finding. And what is a conditional finding? Well, you can think of findings in these reports or in these surveys as kind of deficiencies, if you will. Some deficiencies are weighted higher than others. And the conditional finding is a deficiency that it's pretty significant, and it requires a surveyor to revisit a location subsequently. Fortunately, this deficiency does not impact RT. It doesn't really impact the clinic or clinical functions broadly. The finding, in fact, had to do with the facility itself. So our engineering team and engineering leadership are going to be working to rectify this issue. It had to do basically with air handlers in one of our sterile equipment rooms in the surgery center. So we can expect to see a surveyor going back over to the ambulatory surgery center within the next 30 to 45 days. When they land, obviously they are able to look at things outside of that particular issue. The chances of that happening are very low. But regardless, when that individual does come back to our facilities, I obviously will make the team aware just so that we can be prepared for it. Like I mentioned in our Tiger chat when they had left last week, it's an excellent job done by everyone. And the takeaway obviously is to maintain these practices. We do a fantastic job of making sure that our equipment is within date and that we dress and clean all of our equipment appropriately. And the idea is just to ensure that that practice doesn't drift, or if it does drift, it does so only minimally, and we get back on track quickly. So once again, TJC came and went. Very good survey and extraordinary work, not just from RT, but from all of the hospital staff. Okay, so accounting. We are at the end of the fiscal year. From a productivity and overtime standpoint, this last payroll closure effectively was it for labor costs regarding productivity and overtime for fiscal year 25. So this is really our numbers for that time period. The actual fiscal year, of course, does not close until the end of the month, but for all intents and purposes, for us, our labor costs are concluded. You guys did a phenomenal job. Our productivity is extremely strong. We were able to offset a lot of training. This is new hires. These are folks that are getting cross-trained into our EEG program, and then overtime as well. Last month, we had kind of an unexpected uptick in some sick calls. Obviously, we're able to cover those. But regardless, year to date, we still were able to beat what our metric is, that is 2% or less in a fiscal year. So 1.69 on the overtime year to date. Extremely strong work. Insofar as our staffing is going to remain the same. And the practices for backfilling people that are calling out for kin care or otherwise is going to remain the same. Finance is extremely happy with our performance, and there are no anticipated changes within our department, as far as I'm aware. Okay, so current events, the hospital skills fair. We were supposed to have the hospital skills fair at the end of last month. This was changed, of course. We had postponed it. We now have some new dates. Those dates are in September and again in November. Just like we were scheduling you guys to attend and getting you guys signed up for the specific dates. The same will happen for these dates moving forward. And this happens to coincide with when we do our respiratory specific skills fair. So as you can see in September, it's going to be pretty educational, I guess you could say. September 3rd, 4th, 5th, 9th, and 10th is the hospital skills fair. And then the RT skills fair is going to be September 15th, 22nd, and 26th. So with that said, as you probably remember, there will be a pathways test component of competency for RT skills fair, as well as a hands-on component. The hands-on component will be done on those dates. And I'm currently working on a RT competency packet that I'll be handing out beforehand for that test and for those skills. Some super exciting news. Woodland Memorial Hospital has finally, after a lot of long and hard work from our foundation partners and the community donors, have secured a Da Vinci surgical robot. For those of you that don't know, this is a robot-assisted device where a surgeon can use, as you can see on the slide, robotic arms to do minimally invasive surgeries. This is just, for such a small hospital as Woodland Memorial is, to have this cutting edge piece of technology as part of our toolbox is just, it's phenomenal. Not just for the patients that we serve, but also as a means by which we can facilitate growth and development of this facility through time. You may or may not be aware of the fact that most doctors going through residency, surgical internships and programs, they no longer do the traditional surgeries where they are using a scalpel to open up a patient or open up a site. They are exclusively more or less being trained on these Da Vinci robots to do all sorts of surgery, from heart surgery to hernias and everything in between. So the fact that Woodland Memorial did not have one of these pieces of equipment in our toolbox for our surgeries is was actually quite a negative, made quite a negative impact in our ability to recruit new physicians, new surgeons here into our hospital. So with this coming online, and for those of you that are on site today, they have the Da Vinci set up actually in the Family Birth Center. So if you want to go take a look at the robot as it is fully assembled, check it out. It's really cool. It's in the Family Birth Center. It should be there all day, kind of as a meet and greet, so to speak. So extremely good news. Very excited that we have this in our lineup and in our toolbox. It'll mean our volumes in surgery will go up. It'll mean that our service line will go up because we're actually able to recruit the specialists that will be performing these surgeries. So super exciting news. Then again, just another reminder, this was showcased during our survey with TJC. You collectively do a fantastic job, but just remember, when you're done using equipment or a patient gets DC'd from one of our respiratory devices, just tear it down, clean it, redress it, bag it, tag it, and put it back to its appropriate area, whether that's on the ward or up on our fourth floor. So switching gears slightly, this is a slide that is under RT equipment. It likely should have been RT education. This came to my attention early this morning, so I just kind of slid it into the slide deck. Moving forward, I'll be huddling this and talking about it more often. It was brought to my attention by our infection preventionist, Christina Guzman, that there was a discrepancy in the recorded amount of days that our patients had been on ventilators. So there are certain reports and certain areas within a patient's chart in the EMR that indicate whether or not a patient is currently on a vent. We recently had a patient that got downgraded, extubated, downgraded, and had been moved onto our MedTele unit that had been coming up on a certain part of their chart that they were still on the vent, giving an inaccurate count for the number of days that that patient was on a vent. So after some emails being exchanged with ICU leadership, with our clinical informatics specialist who deals with Cerner-related issues or EMR-related issues, we had found that there is an additional spot that needs to be checked off when a vent is discontinued. So our practice and what I have taught to and what we are oriented to, what I've been oriented to, is that when you start a vent, you do the start time, you do your vent check, you do your charges. When a vent is DC'd, you go in, you put your end time, and you do the rest of your vent check as appropriate, and DC the orders if the nurse or physician hasn't done so already. This aspect was what was pointed out to me, and I don't believe that this is a practice that is widespread through nurses or widespread throughout our department, since this isn't part of the orientation or ongoing competencies, that under settings, under general mode, beyond just putting the vent stop time, we also have to put in ventilator discontinue. So previously, my understanding, what I had been taught, is that as soon as you put in the vent stop time, that was sufficient enough to cascade to all the relevant areas within that patient chart so that any kind of report or data that you would need to pull for analytic reasons would be filtered from that stop time. Apparently, that's not the entire case. That is required, but an additional step is required, which is to have the ventilator activity go to ventilator discontinue. Once you hit both of those, the vent stop time and the ventilator discontinue, that populates or cascades out to all the relevant areas in that patient chart, and hopefully should give us an accurate representation on those reports, how many ventilator days are the patient actually had incurred. Now, as I say this, for the people that are on the call, do you use this in practice currently, or is this new information for you?
I do,
You do, okay.
just because I've noticed it there, so I always mark it. I didn't know if it was required or not, but
Yeah. Yeah, when I was working bedside, this was never something that was required previously, and I think it might be a relatively newer or newish tab. Anybody else on the call that either uses this or this is new information?
Questions?
This is new information to me. I mean,
Okay.
I've seen it in the past, but I just haven't even thought to click it. So
Yeah,
good to know.
yeah. No, fantastic to know. Thank you for sharing. Anybody else? This is new, seen it, use it, don't use it.
It's new to me. I've seen it, but I never used it.
Okay, okay,
Yeah.
okay. Well, thank you. Yeah, like I said, I've been working bedside for a number of years. Obviously been trained on Cerner as it came out as we transitioned from paper charting because I'm old. But it was never something that was taught to me nor an expectation. But evidently this is vitally important for analytic recovery and reporting. So this will go on our huddle board. We'll be talking about it for the next couple of months, make sure that we get this disseminated out to all staff so that if you do have a patient, when they discontinue event, we are putting the stop time, but then also we are putting in the ventilator discontinue. So I thought that was some really good information, and I'm happy that I'm able to share that with you guys today. Okay, new equipment, Airvo 3. So obviously we've had the two new Airvo 3 units for some time. We are nearly complete with our competency. I think we're down to one staff member left to go through the competency, then we can get this machine out in the wild. One of my back burner projects for the department was to go through competencies on basically all of the equipment that we use. This isn't to say that there are any deficiencies or that there has been an incident or that I believe that there is a need for further competencies to be checked off. This is just best practice to make sure that there could be something about the piece of machinery that we have that you maybe didn't know. It could be a good learning opportunity, but more than that, we are just ensuring that you get the education and resources commensurate with all of the devices that we have. Like I said, this is the best practice. It has been on the back burner for a long time. Huge thank you, obviously, to Carrie King, to Emily, to Joanna, for all of those individuals that have been marked as super users that I'm forgetting to name at the moment, that have cross-trained members of the department so that we can move forward and get everybody checked off. As I said, we're nearly done with the Airvo 3s. We are moving into LTVs. After that, we're going to be moving into our pneumatic Vortran vents, and then subsequently just down the line from our V60s and beyond for all the competencies that we can do. I don't just to clear any confusion or any concern potentially. I don't mean that we're going to get to the granular level of doing competencies on nasal cannulas necessarily, but if it's something that plugs into a wall or can be considered a life support machine or maintaining machine, then we're likely going to be doing competency on that. Okay, so RT equipment, again, just another hanging slide about gloves, PPEs, and infection control. This again, perfectly showcased in our recent TJC survey. There were absolutely no findings regarding this across all disciplines. So you guys are doing a phenomenal job. Just again, as a reminder, gloves on when you go in a room, gloves off when you leave a room, and that you're doing the appropriate hand hygiene before you enter a room and the appropriate hand hygiene as you leave. Another hanging slide as far as expectations. Again, it is your hours, your responsibility to ensure the accuracy that the hours that you have done are represented appropriately on your time card, and that at the end of the pay period that you're signing off to ensure that those are in fact accurate. Okay, everyone's favorite slide portion of the slide deck, the employee satisfaction My Voice survey. As I said at the beginning of the meeting, the results for the 2025 My Voice survey have come in. I'm going to do kind of a brief overview of the questions. Then we'll kind of dive in for the remainder of the fiscal year 26, going over just questions that might be opportunities for improvement, things that I can help drive to change and make better for you guys. Overall, just in summary, the My Voice survey came back very positive, which I couldn't be happier about. It's a reflection of how you guys collectively feel that I'm doing as a boss. So it makes me feel very appreciated and feel very good that I am able to sustain high marks through the time that I've been here. So, and again, like you guys know, always here to make things better than they were, and that is going to continue, you know, into the future. So, with that said, this is more or less kind of just a massive data dump of the types of questions that were explored during the My Voice survey. They're always kind of tweaking the data printouts or the way in which the reports are given, and this year is no different. I happen to like the way that they had summarized it last year, but that of course has been that's changed. So this is really just kind of a condensed down version of the overall questions that they asked you during the survey. All of those different categories can be expanded upon to drill down to specific questions. Those questions, of course, we're not going to go over today, but will be in subsequent meetings. So as you can see, you know, relative to previous years, relative to the different hospitals, relative to the organization, very, very high marks. And this just goes on, this kind of wraps up the highlights of the types of questions or categories that were asked. So very good. I am super happy that you guys feel collectively the way that you do about working here. It makes me feel very proud. All right, so promise you we'll go over more of that in subsequent meetings, but just wanted to give you the highlights today. So with that said, moving on, hanging slide again, these are two pieces of resources that are available to you to offset the costs of either licensure, education, both one from your union and one the EdAssist from the facility. Some of your coworkers have already utilized this service with success. It's free money, so I can't emphasize it enough. If there's any way that you can or need to offset the costs for going to a convention, for a certification, I have utilized these resources in the past. Some of your coworkers have too. Just if you need assistance in either one of these, let me know. Let your coworkers know. We're all happy to help you. And again, just as a FYI, if this pertains to you, These are the various classes for ACLS, PALS, BLS. If those are coming up due for you this year, these are the dates and times where skills will be checked off at Woodland. Of course, this isn't the only place that you can do it. You can register through Cascade. You can also register through our CLC. They have many more dates and times available if these ones don't work for the scheduler. All right, Unit-Based Practice Council. Thankfully, we are joined by the co-chair, Danielle. I'm going to hand it to her to give us an update on what they are working on.
We're still working on the policies for being able to do, make our own decisions on what types of treatments our patients should be getting, giving us a little more, I can't even think of the word, but
Autonomy.
autonomy, yes. But I'm almost done typing it up. I just have to run it by you and Dr. Robinson, because he's got to give like the main approval. And then once we have that, I was going to maybe leave it in the department and see if anybody else had anything to add or suggestions. And then once that's done, then we can go through the process of hopefully getting that in our policies and procedures. And then we can get that up and running eventually.
Fantastic. Absolutely fantastic work. This is the RT protocol that we've been talking about for a few months now. With the work between Danielle and Carrie, they have aggregated some really good examples from our sister facilities. They've also garnered some information from outside facilities and really kind of putting together best practices that make the most sense for our department and for this facility specifically. This is a huge undertaking, and I can't be, I'm super grateful that Danielle, you and Carrie are taking this on. From a standpoint of moving this into the future, I, of course, have already planted the seed in Dr. Robinson's ear. Subsequent to that, I will be speaking to our Chief Medical Officer, Dr. Ashley Sens, ultimately because what this entails, as you probably are already aware, it for sure does give respiratory therapists, or the intent is to give respiratory therapists some more autonomy to unilaterally make decisions about the course of treatment for patients that are in the hospital. So with that said, we need to have buy-in. We certainly need to have buy-in from our essentially our chief medical officer for respiratory therapy, which would be Dr. Robinson. He is probably the biggest individual that we need to convince and show to get buy-in from. Subsequent to that, I would imagine that our CMO and the chief of our hospice would be more than happy to get on board with having this go through our policy committees and then really codifying it into respiratory therapies, policies, and procedures. So as you can imagine, this is a task that is not going to happen very quickly, unfortunately, but it will happen correctly, and we'll get a really good policy as a result that we all can use to help treat our patients. You and Carrie working on anything else, Danielle?
I know she was working on the information to give to patients for EEGs and possibly PFTs, but I'm not sure how far she's gotten on that.
Yes, I've actually gotten some information both from Joanna and Carrie insofar as leaflets of information to be mailed out to patients that are not just going to PFT, but also EEG. Since this would be considered an official hospital or like Dignity Health, Common Spirit communication, I had to do my due diligence and figure out if this needed to be vetted through communications, HR, what have you. It turns out that it does. and that other departments do this as part of their normal operations. This is just to give our patients kind of an understanding of what to expect for these various procedures that we're intending to perform. I have sent these communications to the appropriate individuals for vetting. I am waiting to hear back from them to get either a yay or nay or edits, and then we can move forward from there.
Sounds good.
Perfect. All right, very good. Again, just a reminder, scanning scores. I audits our scanning scores daily. This is to ensure that we are, following national patient safety guidelines, scanning the right med for the right patient at the right time. Overall, you guys have consistently do a phenomenal job with your scanning. If there are any kind of issues that come up or patterns that I recognize, I have one-off conversations with individuals, but like I said, as a department, we're doing phenomenal. Just as a FYI, you guys are really good about this. If there's a broken scanner, if there's a broken wow, the important thing to do is to not force that medication through. Get another wow. We have more wows available in the department. I know that it inhibits the workflow in that moment, but it's the safest thing to do for that patient. Also, put in a ticket for that broken piece of equipment so that we can get it back up and running subsequently. But like I said, overall, scanning scores are extremely good in respiratory therapy. Okay, actually pretty exciting. So we've had some pending positions available for some time. These are per diem night shift positions. One's a tier 2, one's a tier 1. After a pretty rigorous interview process and going through a tremendous amount of applicants, today I had reached out to recruiting to extend an offer to Jared Guerrero for our tier 2 night shift per diem position. And then additionally, to extend an offer to a Patrick Johnson for our tier 1 night shift per diem position. I've yet to hear back from recruiting as this was just sent out this morning, but both of these candidates come with some experience. They are relatively new in their career, but they are actively working in different facilities. And both interviewed incredibly well and come with very high recommendations. From speaking with them, they also, most importantly, arguably, seem to be as though they will fit very beautifully into our current culture and our current department. So once I get some confirmation that they have accepted, I'll be disseminating that further to our department. But very excited to announce that offers have been sent out to both of these folks. And kudos. So kudo board for this month. Kudos to Mason for changing out the O2 hose on a V60 because the original hose had a hole. Respiratory therapists are often known to be engineers. Each and every one of us has likely put together something on the fly, and that is part of our charm. Mason has just been called out for his bioengineering prowess. Thank you very much, Mason, for doing that. Kudos to Mike Falloon and the Aloha Award you received for a C-section. This was a recognition from the manager of Family Birth, Zana, and her team. Called out Mike Falloon for his help during a C-section in the last few days. As you can see, the blue lei there on the side was what he was given for that recognition. So great work, Mike. And then, of course, kudos to Taylor for all the help in the ICU. And kudos to everyone in the department for taking the time to recognize each other for the work that we're doing. Thank you very much. I will say, as a side, this was called out just this morning from Celeste. I didn't get a chance to put it on the board. However, Celeste had shared with me that a conversation she had with a member of the community last night particularly wanted to call out the care received in the emergency room. This is a elderly woman that has a history of asthma that utilizes our services in the ER frequently and had gone out of her way to call out specifically Fabian and Elvis for their work, their kindness in the ER when she has been a patient. So huge shout out, obviously, to Fabian and to Elvis for being recognized from members in our community. So excellent work. And with that said, that is all I have. Are there any kudos to Emily for helping? Ah, yes, kudos to Emily for helping with the eBus Bronc. Thank you, Ina, for recognizing Emily on that. Any questions, comments, or concerns?
No, thank you to Ina for coming in and doing it.
The reciprocal kudos is much appreciated. Very good. Let's check the chat. Kudos to Emily for switching his shift to, wow, okay. Feel like we're really focusing on the eBus, which we should. It's a very technical heavy procedure. So again, Marissa says kudos to Emily for switching the last minute. Thank you, Marissa, and thank you, Emily. All right, thank you so much for your attendance, and I will see you all very soon. Have a great rest of your day.
Thanks, you too.
Thank you.